Okay, so we're going to be describing a concept here of hypovolemic shock that was presented to me in a question from qBank. Okay, so this patient was in hypovolemic shock. He had suffered blunt thoracic and blunt abdominal trauma, and he was hypotensive and tachycardic. And it asked us to explain a couple of abstract concepts in the answer choice that was correct. So the correct answer was a small left ventricular cavity with an ejection fraction of 75%. So let's go through some physiology here and try to get this guy diagnosed and try to make the question writers happy that we know our physiology. All right, so to explain this, we look at the mean arterial pressure, the ejection fraction, and stroke volume, and also at the sympathetic nervous system, and some things we can do in the hospital for our patient. So to start off, we have the mean arterial pressure is equal to the cardiac output times the systemic vascular resistance. And the cardiac output is the product of the heart rate times the stroke volume. And then the end-diastolic volume times the contractility can tell us about our stroke volume. All right, so we'll explain what all these things are in just a moment. So to start, our ejection fraction is the fraction of blood, the fraction of the end-diastolic volume that was pumped out of the heart as the stroke volume. Okay, so what that means is we fill our heart with blood before we contract it. Okay, so that's the end-diastolic volume. So at the end of diastole, we have a full ventricle of blood. Okay, and so we want to know what fraction of that total amount of blood is represented by the stroke volume that we pumped out. And if you need to know what the stroke volume is in mathematical terms, we take the total amount of blood that we pumped in to fill the ventricle before we contracted it, and we subtract the amount of blood that's left over after we contract it. So that's the end systolic volume. So this is the full container, and this is the container after we pump out what we're going to pump out after we pump out the stroke volume. Okay, so that's the fraction that we're looking at. And if we manipulate it a little, we look at the stroke volume, it's going to be dependent on the product between the ejection fraction and the end-diastolic volume. So if this guy's undergoing hypovolemic shock, he's losing blood volume. And so if we don't have if we have a lower volume to work with, we're not going to be able to fill the heart as well as we used to, so we're losing end-diastolic volume. So in order to maintain our stroke volume, we're going to need to do something about the ejection fraction. And obviously that would increase, right? But we need to understand the physiology behind that so that we can answer this question. So why do we even care about the ejection fraction and about stroke volume and all that? Okay, so going back to the concept here, our end-diastolic volume times contractility can determine our stroke volume. And stroke volume is important. Stroke volume is the amount of blood that we have to live on. So if we don't have blood circulating through our arteries and coming back to our heart and getting oxygenated in the lungs, the organs in your body get kind of angry when they don't have oxygen. They tend to die and they tend to kill you. So maintaining stroke volume is important. It's so important that the body designed a way to compensate for blood loss when we're attacked or when we lose blood for some reason. So the way that it did that is it created the sympathetic autonomic nervous system. And what that does is it can release chemical substances into the blood, norepinephrine, epinephrine, and those substances will increase your contractility, which is essentially increasing ejection fraction, But this isn't just a mathematical concept, this is actually a physical concept. So if we look at contractility, contractility means a deeper force of contraction. So we're going to squeeze more blood out of the ventricle than we used to. The way that I think about it is like if you're holding a tube of toothpaste. If you squeeze it really soft, you're only going to get a little bit of toothpaste, but if you really squeeze it, you're going to get a lot more toothpaste. So the fraction of toothpaste that you squeeze out, the fraction of the total toothpaste you squeeze out is going to be a much larger with a higher contractility than it is with a lower contractility. So it's all about the fraction of the total blood that you're squeezing out. So we can measure that, which is nice. Things that we can measure in the hospital are really nice because then we can explain it to the people that are caring for the patient, and we could also use it to adjust our care for the patient. So that's one thing that we do with the sympathetic nervous system. Another thing is we can increase heart rate. So those same chemical substances, norepinephrine, epinephrine, come out and they increase heart rate, and we can measure that. Okay, so increasing heart rate is actually a vital sign. It tells us whether our patient is alive or what their vital status is, the status of their life force. All right. So why do we need to know that? Why do we need to know their heart rate? Well, heart rate times stroke volume is going to equal cardiac output, and if we can increase cardiac output, we can maintain the mean arterial pressure, keep our organs perfused, and keep our patient alive. So we dealt with stroke volume by increasing contractility, and we dealt with heart rate by increasing basically our heart rate. So we've increased heart rate and we've increased stroke volume, we've increased our cardiac output, and we've maintained our mean arterial pressure. All right. So if we're good on that, we can move forward. Okay, so next we have to figure out, why do we have to know our chamber size, the size of the chamber, of our left ventricular chamber? So we can measure that with an echo. Okay. And why is that important? Well, let's try to understand it first, and then we'll tell you why it's important. So we have three things that can happen. It can be empty, it can be normal, it can be large. So if it's empty, you're dead. If it's normal, then you're alive. If it's large, then you're diseased. But if you're normal, there's a range of normal. And what the machine spits out is left ventricular end-diastolic volume. So end-diastolic volume, that's the amount of blood that we filled the chamber with, the left ventricular chamber, before we contracted the heart. So we filled it up as much as we can before we contracted it. But that volume that we filled it up with, it has a number on it. Okay, and that tells us about the size of the heart. So that number is between 35 to 75. So if we're not filling it up appropriately, it'll be toward the lower range. So what I mean by that is if we don't have any fluid to fill it with in hemorrhage or hypovolemic shock, then it's going to be more toward the lower range. If we're overfilling it, say for instance in like CHF or something like that, some high volume status, then it'll be more toward the upper range. So that's why that's important. But what's even more important is that you understand this concept so that you can answer questions. And so the answer to this question was, this patient will have a small left ventricular cavity with an ejection fraction of 75%. So they wanted you to know that the normal ejection fraction is about 67%. And so they're going to have an elevated ejection fraction, obviously, because we let the sympathetic nervous system take over for our stroke volume. And it thinks we're dying, so it's going to overdo it. So it's going to increase our ejection fraction up and above the normal of 67, up into the 70s. Okay, so the other half of our answer said that we're going to have a small left ventricular cavity. Well, we're volume down. So we're going to be on the lower end of normal because we have very little fluid to fill it with, because it's leaking out of our body. So you're going to be on the low end of the left ventricular chamber size. So now that we know that, we can answer this question. But if you want to take this a little bit further and complete the story, the sympathetic nervous system does one additional thing. It also increases systemic vascular resistance by clamping down and vasoconstricting all of your peripheral vasculature, your peripheral arteries, so that your central organs can be perfused, your brain and your heart and your lungs, and things that are necessary for you to survive. So you don't want to be perfusing your fingers, your toes, your penis or vagina or anything that's non-essential. All non-essential personnel need to stay home when you're bleeding out. So that's one other thing that the sympathetic nervous system does. So your patient's going to be cold and clammy. All right. So I hope that helps you to understand it, and we spent enough time on it. So I'm thinking this will help you to answer at least 6 or 7 different questions on the exam. Let me know what you think in the comments below, and don't forget to subscribe. Thank you. Have a nice day. Bye.